Hello, hello. What's up, folks? Happy Saturday. Thank you for joining us. This is round 2 of the VMR recap. So what we're going to do today is we're going to touch on all the 6 cases that we talked about this week. And the best part about this VMR is that you're going to have 6 or 7 different people chiming in. But hopefully the goal is to have everybody participate and everybody ask a question or share a reflection or whatnot. And so because we have 6 cases to discuss, which means that we have less than 10 minutes per case, we're actually going to jump right in. And we'll start off with Sunday's case that Mukund will summarize and share the highlights for.
Great. Hello, everybody. I was really excited to present this case at the summary because the day before, this always happens at VMR, the day before this case, I had just watched my lecture on colonic polyp disorders. So it was good timing. And thank you to Nikita for presenting it. It was a really good case. This was a 20-year-old female, unresponsive after 2 episodes of hematemesis with 50 to 100 milliliters of frank blood. For 4 weeks before, had severe abdominal pain. For the first 2 weeks, had black tarry stools, melena, and for the last 2 weeks, no stools at all, suggestive of a bowel obstruction. Had 2 episodes in the past that did not require admission, or rather, they did not present to the hospital for either of these episodes. And I believe one of those episodes was as young as 6 years old. So the case discussion was also really interesting and very educational. I think just a very practical discussion that hit on a lot of really high yield points. So I'll go over a couple of these. And this will lead to, I think, one key question that was unresolved by the end of the case. We started with a differential on hemoptysis or hematemesis, starting by organ system, classifying it either as upper airway nasopharyngeal from the lungs or a gastrointestinal source. And especially if it's nasopharyngeal, could it be due to a coagulopathy, an infection, or a chemical exposure? We moved on to talking about kinds of hemoptysis or hematemesis. If it's frank red blood, it's most likely an active bleed, an ongoing bleed. If it looks more like coffee grounds, it's more likely an occult process, something that's happening more slowly. Just given the variety of symptoms that this patient was experiencing, we thought it was most likely a GI bleed. And especially because of the history of melena, we thought it was an upper GI bleed. 90% of upper GI bleeds have a source that's above the ligament of Treitz at the terminal duodenum. And the most common causes of upper GI bleed, if we're activating our CP solver schema, is peptic ulcer disease, esophageal varices, or esophagitis. In this patient who's young, 20 years old, with no significant past medical history besides these episodes, variceal bleeding is unlikely as there's no evidence of liver disease. Esophagitis could be a possibility, but the chat had brought up tons and tons of other really interesting suggestions. Malignancy, of course, a possibility. Dewlefoy lesions, which are tortuous, malformed arteries, they're most likely formed in the stomach lining and cause mostly occult bleeding, but can sometimes be significant. Arteriovenous malformations anywhere in the GI tract, and given the patient's age, Mallory-Weiss mucosal esophageal tears became a little more likely, a little higher up on the differential. We didn't really ever get to the source of the bleeding, so we moved on to talking about probably the more emergent concern here in the bowel obstruction that we thought could be leading to quite a few of the other symptoms. And so we went into our bowel obstruction schema. Small bowel obstruction, more common than large bowel obstruction, also made more likely, as we said, given the history of symptoms. Here, as we've talked about, adhesions and hernias are most common, but somebody in the chat, I think, made a really interesting comment that because the episodes had started as early as 6 years old, we should consider genetic pathologies of the intestinal tract. So I'm going to do a quick review of some of the more high yield intestinal genetic pathologies, which I thought were really interesting and were good for me to learn. A lot of these were new to me. We'll start with hereditary hemorrhagic telangiectasia, or Osler-Weber-Rendu syndrome, which is an autosomal dominant disease of vascular malformation. Most often you see epistaxis and intestinal telangiectasia is causing GI bleeds. But you may also see more significant arteriovenous malformations in the pulmonary, hepatic, or cerebral systems, which may lead to stroke, cerebral abscess, so on and so forth. As far as polyps go, we thought about bleeding symptoms for a little bit, but I think this was Jack had said that blood causes gastric motility, and a hematoma in the GI causing a bowel obstruction was pretty unlikely. So we moved on from talking about causes of bleeding to more physical causes of obstruction. We talked about polyps for a while. Peutz-Jeghers syndrome, which ended up being the ultimate diagnosis, came up pretty quickly. It's an autosomal dominant gastrointestinal hamartomatous polyp syndrome. So benign hamartomas, but with a risk of colon or breast cancer that grow across the GI system, but especially in the small bowel. And it's differentiated from another pretty similar syndrome, juvenile polyposis syndrome, by the presence of pigmented macules on the lips, a variety of other areas too, but most commonly on the lips. And these are pigment-laden macrophages. We talked about mecyldiverticulum as a possibility, serving as a lead point for intussusception, telescoping of the small bowel, most common at the ileocecal junction. Although, I did a quick lit search and I didn't find really anything to suggest that intussusception is associated with significant hematemesis or hemoptysis. So, this is still an unexplained phenomenon here that we're dealing with in the background. And the last couple of things that I wanted to highlight were the malignant syndromes that often present in youth, starting with familial adenomatous polyposis, FAP, or its variants. There's Gardner syndrome and Turcot syndrome, which present with other cancers or other growths. This is a tumor suppressor APC mutation that leads to hundreds of polyps that form at a young age, starting as young as in the early teens, according to some reports, but with a 100% chance of developing colon cancer unless you perform a prophylactic colectomy. We didn't think that this was necessarily the case, just given the family history. We also talked about Lynch syndrome very briefly, another microsatellite instability-based hereditary cancer syndrome. However, most people don't develop symptoms for Lynch syndrome until they're much older, and this patient was only 20, so that was ruled out as well. Any of these we thought could serve as a lead point for intussusception, and that ended up being the case. By the end of the case, we saw that there was imaging findings with that characteristic target sign suggesting intussusception and small bowel obstruction. So we solved the case in that way. There was a biopsy, I think, somewhere that confirmed Peutz-Jeghers, but we still don't know what the upper GI bleed causing hematemesis is from, and that remains unanswered.
Cool. That was absolutely superb. I think what a walk through the initial concern, and then the finding of the bowel obstruction as a pivot point, and then a really in-depth review of all the polyposis syndromes. It's crazy to hear how much morbidity is associated with many of them, and the rate of cancer associated with each of them. And I think that if you take a moment to reflect on each punctuation in the case, I think hematemesis is a really good example of a phenomenon that we'll talk about all the time, where you actually have to have multiple different approaches. The anatomic approach, which you outlined here, is so memorable. It makes it so easy to stick because you already know your anatomy, right? And so what you're doing is you're applying your anatomy. You're like, oh, this could happen here, this could happen here, this could happen here. And that is an approach that's going to be easily memorable. And the question is, when you're the frontline provider taking care of somebody who has hematemesis, is that what you're going to do? And the answer is no, not really, because the frontline provider doesn't have an endoscopy camera. If you did, you would just somebody would come in hematemesis, you'd be like, all right, let's take a look, and then we'll find the lesion. And because we don't have a camera to actually figure out what's going, we have to use proxies. And the proxy here, the most important proxy, is determined by morbidity. So the most morbid cause of hematemesis is related to portal hypertension. So you'll see that the provider who meets the patient initially is asking a key question: is there signs of portal hypertension, i.e. cirrhosis, or not? because not only does that help select for the most morbid causes of an upper GI bleed, it pushes you to treat the patient differently. So there's the core bundle, which everybody with hematemesis will get, which is 2 large bore IVs, fluid resuscitation, type and screen, consent form, and an IV PPI. That you'll memorize. By the time you're done with intern year, you'll have memorized that. But patients with cirrhosis need 2 other things. Any takers from the crowd on what 2 other things a patient with portal hypertension or cirrhosis need? Yes, Rafa, 100%. Octreotide and antibiotics. And octreotide is to lower the portal pressure, and antibiotics is for STD prophylaxis. So up front, you're thinking, is this patient with portal hypertension or not? I think that's a key figure. I have absolutely nothing to add to your reflection about intussusception and polyposis syndromes. I think that was a great overview, and some people got a little heebie-jeebie from their step 1 days, and some people really appreciated that notion because of maybe it being an active part of their lives right now. Awesome. Any questions about that case from the crowd? From anyone, really? I'll mute for about 30 seconds before we move on to the next one. Pop your questions either on mute and say them out loud, or
I had a question. So I wanted to ask for the role of vasopressin instead of octreotide in such a situation.
yes, 100%. Marush, I don't think we've met before. Do you mind introducing yourself?
So I am a graduate from India. I graduated from PGMS Rohtak, and I'm currently working as a research fellow at Mayo Clinic, and I'll be applying for this residency match this year.
Oh, wonderful.
If you remember Jasimran, I was Jasimran's roommate. So
oh,
we did.
incredible. Oh my gosh. Wow, of course.
So
Anyone
he introduced me to this platform, and it has been amazing.
Incredible. We'll all see how many people are rooting for you for the match in this year, and we're get to know you better. And of course, like if you're Justin runs in his circle, you're part of the VM family for a long time. So octreotide and vasopressin actually by name are the same medication, but they're actually very different. So octreotide and vasopressin, or arginine vasopressin, fundamentally act on different receptors. And so even though they are this essentially a very similar molecule, I forget which one, what the name of each receptor is, but the fundamental things that you need to know about octreotide and vasopressin is they are closely related molecules that engage different receptors. And those different receptors have vasoconstrictive effects, but where that vasoconstriction occurs is a little bit different. So the role of octreotide is to vasoconstrict and reduce the inflow of the portal circulation, or the splanchnic circulation. So what does it do? It reduces the inflow by squeezing down on the arteries that feed the gut. And when you have less blood flow going to the gut, you have less contribution to portal hypertension, because what normally happens is those vessels are massively dilated. That's called splanchnic vasodilation of cirrhosis. And so that blood comes in and then goes into the portal circulation, worsening portal hypertension. So that's what octreotide is. It constricts those blood vessels, selectively reducing flow to the portal circulation. Vasopressin, in stark contrast, is a systemic vasoconstrictor that is used as second-line therapy for distributive shock, and has a much more diffuse effect on arteries. So mechanism is very similar, vasoconstriction. The names are different because the drugs are slightly different, and octreotide is much more splanchnic selective versus vasopressin, which is a diffuse blocker.
Okay, thank
you. Does
that
answer your question?
Yeah, it does. And if you had to compare between these two, which is the better medication to give in such a situation?
Yeah, so in this situation, the question, reformulating that question, which one is better? It depends on what you're trying to do. If your goal is to reduce portal hypertension, octreotide is the name of the game. If your goal is to augment systolic blood pressure in a patient with distributive shock, then vasopressin is what you would use.
Okay, thank you so much.
Thank you for that great question. Other questions, folks?
I had a question, but I'm not sure if we want to dive into it or jump to another case.
No, go for it, please.
So during the VMR, Jack, actually, Mukund, you walked us through how there was both, signs of an upper GI bleed and also SBO. And Jack actually framed this in a really interesting way during the student VMR. And that is kind of what led to what. So did the SBO lead to a GI bleed? Did the GI bleed lead to the SBO? Or was there something else, like maybe in this case, the polyp that can cause both the GI bleed and the SBO.
Yeah.
So I think my question is, when you have, we have this kind of schema for GI bleed and small bowel obstruction, and kind of when you have that overlap, is there one you should be focusing on because of the morbidity, or how should the small bowel obstruction kind of influence how you're working through the schema of the GI bleed?
Yeah, no, I think that just to acknowledge the fact that this is a very rare situation. So usually when you're dealing with gastrointestinal bleeding, you're not dealing with obstruction. And so these worlds are very, very separate. And if you look at the causes of an upper GI bleed, they won't include a small bowel obstruction. If you look at a small bowel obstruction complications, they won't necessarily include an upper GI bleed. And so the question is, well, what's happening in this case? And I think what I would do is I would really acknowledge how much I know that a patient is actually bleeding in their GI tract. I know for a fact they're having bowel obstruction, but it's not uncommon that patients who have hematemesis actually just have slightly abnormally colored vomitus, or yeah. So I wasn't there, and I think that none of us were really seeing the patient. So that's always none of us on reflecting on the case in terms of the reasoning we're seeing the patient. So you always want to step back and say, like, is this actually blood? But I think in this case, I think the small bowel obstruction is probably the dominant finding. And the reason for that is as long as you're having a non-cirrhotic bleed and a bleed not related to another morbid condition called an aortoenteric fistula, GI bleeds are usually okay. They'll figure themselves out. A small bowel obstruction can, but not so much. So if I were to guess, I would guess that this person had intussusception from a polyp, and another polyp happened to be oozing at the same time. And the fact that there was an obstruction allowed the blood to collect and become exaggerated in its significance, and that blood slowly would have otherwise trickled away. That's how I would put it together, that the bowel obstruction collected the blood. So that's, yeah, I think the biggest learning point is bowel obstruction and a GI bleed are usually unrelated problems, and connecting them would be a monumentous effort.
Okay, that's helpful. Thank you.
Yeah, for sure. For sure. All right. Thanks, y'all. And Mukund, that was superb. Thank you again for recapping that case. And that was a really, really educational one. All right, Ariel, you're up, my friend.
We am Tuesday. Isn't there a Monday?
Oh, sorry. Oh my God. I thought we were Monday. That's right. Oh, I skipped over Rafa, which I'm, it's
He
funny.
did on purpose.
Yeah, no. I very likely did it on purpose, but I actually texted both Rafa and Ariel right now, and then I completely forgot. So yes, Rafa, take it away, please.
So I'm going to recap using 4 questions that Rabbi once taught me whenever I'm dealing with a clinical unknown, which is who, what, when, and where. So who was this patient? So this was a 37-year-old male. He had HIV for a week, just recently diagnosed, and not went to biotherapy. I usually try to combine what and when because it makes more sense for me. So what is the clinical syndrome and for how long this patient has been having it? So this patient has been having fever and weight loss, 30-pound weight loss for 3 weeks, and also a rash for 3 days. And where this patient was established in Midwestern USA with no recent travel history. On exam, it was remarkable for a high temperature, tachycardia, anterior cervical lymphadenopathy, hepatosplenomegaly, and intramacular rash associated on the abdomen, back, and proximal extremities. His labs are remarkable for low CD4, a high HIV viral load, pancytopenias, negative serologies, including hepatitis, syphilis, and toxo, elevated alk phos, AST, ALT, but normal total bilirubin. Chest X-ray was remarkable for preeminent peripheral lymph nodes, and labs also revealed elevated LDH, elevated ferritin, decreased fibrinogen. He was ultimately diagnosed with disseminated histoplasmosis since there was intracellular encapsulated yeasts within the white blood cells. So that was the sum up of this case. So my first teaching point that I would love from Dr. Bill is that whenever we see elevated alk phos, we have to think first, oh, is this coming from the liver, or is this coming from the bones, or is this coming from the placenta? So the next thing you should do is to check the GGT, and if it's elevated, it's certainly from the liver. So if it's elevated alk phos, you know it's from the liver. And we saw that there was this pattern that like elevated alk phos, even more elevated than the elevated ACT-ALT, you have to think about a cholestatic picture. But that was not the case because the total bilirubin was normal. So in this case, when you see elevated alk phos, much higher than the elevated ACT-ALT, but a normal bilirubin, you have to think about infiltrative disease then. So think about infection and malignancy. Do you want to add something else, Arabi?
I think that is such an incredible teaching point, honestly, and I'm not surprised that Tony Brewer emphasized it. Of course, on the backdrop of a crazy case, which, yeah, I think we'll leave be for other folks to have questions about. But I think interpreting alk phos is a little bit tricky, and I will tell you that there's that tension is always there. Is it liver or bone? And I'll share one pearl and one pitfall. So the pearl is bony alk phos is almost always very painful. So in that case, you might have guessed it's liver even before the GGTs come back because the patient didn't have any bony pain. It's very hard for alk phos to come from bone for the patient not to be hurting. So I think that's one very, very prominent clue. Now that's the pearl. Here's the pitfall. I'm going to tell you a number. Alk phos is 500. GGT is also super high. What can you conclude? What do you think? High alk phos, high GGT. All right, Arush. There's common bile duct obstruction. That's true. That could be one of the possibilities. You know for sure that the patient has liver involvement. But here's the thing to pay attention to. How have you ruled out concomitant bony problem? Metastatic hepatocellular carcinoma, metastatic tumors, histoplasmosis going to liver and bone. You have to be careful. So elevated GGT confirms hepatic involvement, but does not exclude concomitant bony involvement. Your next question will be, since you're a wise group of people, is, well, does the height difference matter? Like if the alk phos is super high and the GGT is only a little bit high, can I infer that there's bony involvement? Unfortunately not. It doesn't, people have looked into that, it doesn't help much. So if you tell me that the alk phos is high and the GGT is high and the patient doesn't have pain, I'll believe it. I'll say there's probably no bony involvement. So the pain variable is key. So if you look at that whiteboard, alk phos is high, GGT is high, and the patient's not in pain, I think you're probably comfortable saying it's hepatic involvement. Yeah. Well, any other learning points you want to reflect on, Rafa?
Yeah, sure. So in the end, we saw that this patient actually have a histoplasmosis with HLH associated picture. And I think it's good to remember what is HLH and what are the triggers. So it's basically a life-threatening syndrome with excessive immune activation leading to immune dysregulation and tissue damage. As people were talking, that could be a primary or a secondary problem. Primary problem, people are born with genetic abnormalities, really rare. Secondary are due to triggers. We talk about one right now, which is the fungal infection, disseminated histoplasmosis, but also bacterial, viral, especially EBV, protozoal as well, malignancies, especially heme, like lymphoma. Autoimmune, the most common ones would be systemic juvenile idiopathic arthritis and SLA, and finally immune deficiency syndrome. When you can, like in a clinical case, suspect of HLH. So this patient had like the elevated LDH, the elevated ferritin, the decreased fibrinogen. Actually, there are 5 criteria, if I'm not mistaken, and you have to like select 5 of them. So this patient, they didn't give us the triglyceride, for example, but that would be elevated as well.
Amazing. You know, HLH is so rare, but I feel like if you hang out on VMR, you'll think it's like more common than community-acquired pneummonia. And that's a brilliant breakdown with the emphasis is on all the lab stuff. I have really nothing to add to it. Yeah, we'll open it up to the crowd to see if anybody has any questions.
I actually had one question that
Yes,
came
Emma.
up. Oh, sorry. It was basically can he have only disseminated histoplasmosis without saying that he also has concomitant HLH, or do we say both?
Yeah.
Okay.
Yeah, I think that's a superb question. I know, Rafa, you dive deep into it. Do you have any opinion or thoughts?
I believe that patients with disseminated histoplasmosis most often don't fit the criteria for HLH.
Yeah.
I think HLH with disseminated histoplasmosis is part of a much more broader, you know.
I completely agree with you. So, okay, so for the next 2 minutes, I need you to delete everything you know about HLH, and I want you to try on these shoes, okay? If these shoes work for you, perfect. HLH is basically like getting peripheral smear or a diff with eosinophilia. It's just a kind of inflammation, okay? No different than a neutrophilic leukocytosis or an eosinophilic leukocytosis or a monocytic leukocytosis. But the best analogy is actually eosinophilic leukocytosis. Why? You only need to know about one thing about eosinophilic leukocytosis. It has a unique DDX like parasites and EGPA and whatnot. But more importantly, no matter what the cause is, the eosinophils themselves destroy your body. So no matter what you have, those eosinophils will eat your heart and actually cause strokes. So treating eosinophilia over 5,000 is a medical emergency no matter the cause. So if you're taking care of a patient who has eosinophils over 5,000, you will give them steroids, even if they have strongyloides infection, because the risk of eosinophil-induced damage is too high. And that's HLH. HLH is a unique kind of inflammatory reaction in response to a trigger. And the only reason that HLH is special is because the inflammatory response itself can cause devastating, life-threatening damage. Okay? That's the key principle. Why do we talk about HLH so much? Is because the inflammatory response is too strong. Now, what triggers HLH is no different than what triggers eosinophilia, certain kinds of infections, certain kinds of autoimmune diseases, and certain kinds of cancers. And when you study the pattern, you'll realize that it's all intracellular organisms and it's all liquid malignancies. So there's some kind of dysregulation of the cell signaling that's happening for bugs intracellularly, CMV, EBV, histoplasmosis, TB, they're all intracellular organisms, or lymphomas and leukemias. So the question, does this person have HLH, or do they just merely have a very bad aggressive infection or aggressive cancer, is actually impossible to answer. What the real question is, am I worried so much about the inflammatory response from this process that I need to suppress it? So in addition to chemotherapy or antimicrobial therapy, do I need to shut down this person's immune system? That's the question. And unfortunately, unlike eosinophilia, where the level is clearly defined as greater than 5,000, there's no good way of measuring how bad this HLH is. So it's often a gestalt. And so what happens in real life is somebody's really sick and you just treat them and then you figure out the cause. You're much more likely to also make a cancer better because the treatment for HLH overlaps somewhat with the treatment of cancer. You're definitely going to make an infection worse. So most people with an infection-induced HLH will be okay if you find the infection and treat it without treating the HLH. Most people with cancer, there's less impetus to not treat them because the cytotoxic steroids and chemotherapy, etoposide, for HLH will also quell the cancer, but it'll make the infection worse. So you'll see many more people with an HLH-like reaction be formally diagnosed with HLH when they have cancer as the cause, and they'll be much less likely to diagnose with HLH when they have infection as a cause, because all you want to do is stop the infection, and you know that you can usually get the infection under control in a matter of hours or days. So does this patient have HLH? It doesn't really matter. It's really, do they have it bad enough that you need to treat them for it? I think that's really what it comes down to. And somebody with histoplasmosis, they should be better in a couple of days of amphotericin, 2-3 days. So usually you can wait. Did that answer your question, Chima? Awesome. All right, Ariel, you're up, my friend.
Cool. I hope I finally found a quiet enough place. I'm in a conference.
Oh, no.
So My teaching point is actually like a branch off of the
Yeah.
case. The case itself is pretty straightforward. I highly recommend everybody to like watch it. The case, to briefly recap, is a 77-year-old man with a hip fracture, prepping for surgery, having acute dyspnea and altered mental status. And this is a POCUS session, and through the POCUS of the lung and the abdomen, we were able to zero in on the diagnosis pretty quick, which was cystocerebral syndrome causing the altered mental status, which I would elaborate on a little bit more, and acute heart failure with fluid overload causing the dyspnea. So I found it really interesting that cystocerebral syndrome totally was not in my bank. So I did a little bit more research on just acute and maybe subacute urinary retention. Point of care ultrasound, we can use that to diagnose that. But Robbie, in a recent RLR episode, reminds us that when we see fluid in the abdomen where we think might be the bladder, we need to be careful because it can be intra-abdominal fluid or subcutaneous fluid that looks like urine. So we don't want to miss ascites or even hemoperitoneum. But if we know that it is acute urinary retention, then Robbie again reminds us the approach to that is pretty similar to any situation where something is supposed to move, but it's not moving. I really love that schema. So it's either an outflow obstruction, which in senior males, the BPH is the most common. But then we can also have like a blood clot, a stone, a mass, a stricture from previous catheterization or trauma causing the outflow obstruction. And if we can rule that out, then we are looking into a motility issue, which can either be from neurologic impairment, thinking myelopathy or other form of central lesions. Don't forget about cauda equina. But we would probably expect to see some other neurologic symptoms with those two. And there's another cause of HSV, sacroradiculatis. Sorry. So that we can look for rash in the region. There are a wide array of medications that can cause urinary retention, sympathomimetics or anticholinergics, antidepressants, antipsychotics, and in our case, opioids, which is commonly used in these trauma patients. We're also like fluid, resuscitating them. But then if the opioid is causing them not to pee, then we're having a problem. Theoretically, UTI, especially if overlying on BPH, could cause urinary retention because of the inflammation and edema of the urethra, but Robbie says it's quite uncommon to see that alone. There are like postoperative or postpartum urinary retention. And then if the patient is like had prolonged urinary retention, they could have bladder atony. And then on another like interesting RLR episode, we learned that there's like this really, really rare like volitional is how Reza put it, like a psychotic, like really psychotic patient just like holding the urine. But when people ask him to pee, he can. If people don't ask him, then he'll just retain a lot of urine and causing discomfort. So maybe there's like a frontal lobe lesion causing disconnection from the brainstem, like reflexes. We don't quite know, but something interesting. And then branching off to the consequences of acute urinary retention, worry about the postrenal AKI and the life-threatening hyperkalemia, apparently. We talked about bladder atony, but then there are two like rarer manifestations. Again, another RLR of a vagal event, like I think is an older adult with like a bradycardia of like 27 beats per minute, and there's no arrhythmia or anything, and they found out it's just because he had a really distended bladder. So that was fascinating. And then again, back to the Tuesday case, cystocerebral syndrome, which the pathogenesis would be a distended bladder activates adrenergic receptors and locus coeruleus, causing hyperarousal, which in turn cause encephalopathy and delirium, and then that can cause cognitive impairment, which was super cool, adding something more to my altered mental status schema.
I can't believe you just did that. I think you're putting all urologists out of business here. This is like literally a comprehensive schema. And I think you taught us to be cautious before you entering that schema, because there's no test short of actually removing the urine that is definitive for urinary retention. We use an ultrasound as a proxy, but sometimes we see fluid, but we don't know where that fluid is. So being confident that's in the bladder requires you to do a catheter. So your schema has a mimic. Your schema has the causes and the consequences, and the causes again are just so powerfully put. It's either obstruction or neurological issues. And how can you? I think you taught us something important, which is how can you have neurological issues with no neurological deficits? And the answer is extremely unlikely unless there's medications involved. So the medications cause a local neurological dysfunction. So it really is. Are there neurosymptoms involved? Yes or no? Are there medications involved? Yes or no? Because there's no neurosymptoms, you can eliminate most of the neurocauses except the medication. So I think it was really telling this person. And then also the bladder brain connection and the bladder heart connection are very, very humbling, and goes to show you how a tiny little sac in your pelvis can cause you to be obtunded and cause you to almost die from bradycardia. So very, very humbling. So make sure you all pee healthily and regularly. And this is for Deborah, who is a big proponent of hydration and as a result urination. Any questions from the crowd?
Sorry, one more thing.
Yeah.
You know that when you get me, you get a plugin for veterinary things. Just
Of
one
course.
sentence. If any of you have a male cat, just be really careful to monitor the urinary outflow every day, because they have a teeny tiny urethra and they get plugged really easily, and it can soon become a life-threatening emergency. Make sure your male cat pees.
That should be your tagline, Ariel. I think it's so good. Wow, what a wonderful pearl. All right, friends, any questions about this case? Just unmute and say it out loud, please. We'll wait for 30 seconds, otherwise we'll move on. All right. Wednesday, Madalena, take it away.
Okay, Wednesday. Well, I guess before Wednesday, I just wanted to highlight that in Tuesday's case, Ravi gave such an awesome teaching of the differential for B lines. And that was also, in addition to the beautiful takeaways Ariel wrote, you described, I think the B line differential was so helpful for me. Okay, Wednesday's case was really interesting. So to kind of briefly summarize, to me, there are kind of two phases of this case. The first one was really about this gentleman coming in for a pacemaker placement, and then after that was done, kind of this gross hematuria that the patient noted. But I'll kind of give a short summary and then I'll jump into some teaching points. So this was a 70-year-old man who was admitted into the hospital to receive a pacemaker. Actually, a few months prior to admission, he had a STEMI that was actually more or less asymptomatic. The patient just felt vaguely unwell. He went to his PCP and then was noted to have a STEMI. And then follow up after that STEMI and follow up with his cardiologist, he was noted to have some arrhythmias and was put on a cardiac rhythm monitor. And from that rhythm monitor was noted to have some bradyarrhythmias and then intermittent complete heart block, which was why he was referred to get a pacemaker. So one of the teaching points I have here was just kind of the general categories for why people get a pacemaker in the first place. And I actually wanted to open that up to the chat to see if anyone was there who wanted to summarize that, or just any ideas, even if you weren't there, kind of why do people get a pacemaker in the first place? Awesome, Rafa said high degree AV block, sinus degeneration. Yeah, exactly. So kind of the two categories that Steph summarized were the first one, just any symptomatic bradycardia. for AV block. And then the second one is asymptomatic, but a kind of concerning higher degree AV block. So that could be like an asymptomatic 3rd degree heart block, for example. And so this patient kind of fell into that second bucket. What I did want to move on to was, I thought the physical exam was really fascinating, and Amir, who I think is on this call, just walked through some really awesome pathophysiology. So Amir, if you're okay, I would love for you to kind of unmute and share, but just to summarize, so for the vitals on this patient, there was a discrepancy in the heart rate between the heart rate obtained from auscultation and then the heart rate obtained from kind of the pulse oximeter. So the heart rate obtained from the pulse oximeter was in the 40s, but on exam, it was in the 70s to 80s. And then in terms of kind of the cardiovascular exam, what was interesting is that the heart rate was regular for several beats. And then occasionally every other beat, there was kind of a slow intermittent systolic murmur, but the murmur was only heard with the regular beats. And Amir just walked through some really awesome pathophysiology in the VMR. So are you willing to unmute and share why that was?
Yeah, would be happy to. So it was basically, it's very interesting how you somehow discover that you know something when someone prompts you with the right questions. And so it was a case of that where it makes sense that if you have a non-perfusing beat of the heart, such as a premature ventricular contraction that might start at the top and go down or start somewhere, so it's not regulated properly, that it will not perfuse. And so it was very interesting to see that it might cause a heart sound, but without a murmur, because it's not passing through the valve, and it's not going to be detected peripherally. So from that, I think I will definitely try to remember to always check the pulse from peripherally and with auscultation. And I think there was another very interesting thing we learned that I was just thinking about, but I forgot. Maybe if I remember it in a minute, I'll say something. But very, very nice case.
Yeah, I know exactly what you said. I thought that pathophysiology was really fascinating. So you have these early ventricular beats that are non-perfusing because the stroke volume generated isn't enough to feel the pulse. So that kind of explains the discrepancy there. I know we're short on time. I just kind of wanted to open up to Amir or anyone else who was there if you had any questions about this case. There was kind of a hematuria component that we kind of reframed as pyuria with a small hemorrhagic component given the UA findings. But I just wanted to open up to see if there were any questions.
Can I just say what I just remembered, because I think it was very important and I had never thought of it that way. And we were told that if you ever have atrial fibrillation and a regular heartbeat, it means you have a full degree, 3rd degree block. And I think, yeah, it's just one of these things that you pick up along the way. That's very nice to remember.
I also thought that was such a great pearl. I kind of watched the YouTube because I wasn't there, and I had to kind of go back and re-listen to that so many times. But exactly as you said, AFib should be irregular. So if the ventricles are beating with a regular frequency, then that means the atria are not getting, or the ventricles are not getting input from the atria, so it's a complete heart block. That was, I thought, a really great teaching point.
Super quick.
This case was crazy because the patient was referred for pacemaker replacement for bradycardia, who also had pseudobradycardia, which is like basically when you're faked out that the peripheral pulse is normal. And I think that the general theme there, as you outlined, like as the conversation is, why would a ventricle contract, i.e. cause a heart rate, but not have enough blood to eject? That's really the principle, right? Like the ventricle contracts, so there is actually a registered QRS complex on the EKG, but not enough blood is ejected. And so that's why it never makes it to the fingertip, right? And so there's only really two reasons that happens. One is that the ventricles are contracting so fast that there's not enough filling, diastolic filling, or two, that the contraction, the signal for contraction was abnormally timed. And so the ventricle squeezed well before it should have, prematurely, PVC, or PAC. So if you're asking yourself, why does this patient have pseudobradycardia? It's usually because they have a super fast rate, or they have a P something, PAC or PVC. And I can't tell you how many times I've had patients whose heart rates are 20 or 30, and I'm like, what? You're here for sniffles. Why is your heart rate 20 and 30? And then you're like panicking, you're calling a bed, you're maybe getting a rapid response. And then you see on the EKG that it's just many PVCs. That, if it hasn't happened to you yet, will happen to you soon. I see that there are a lot of questions in the chat, but what I'm going to try to do, because so many people have put so much hard work to prepare, is I'm going to ask us to move on to make it to the hour mark, and then we'll field any questions along the way. Does that sound okay? Okay, perfect. By the way, time management on my end, very, very, very poor. My apologies. I just kind of got lost, and it was everyone did all this work, and it was my job to keep us on time, and I failed miserably. But I'm actually going to jump to Promise first. This is jumping into Friday's case, and then we'll jump back to Thursday with Shane.
So, hey, I will try to keep it short. So basically, we had a 77-year-old female with a progressive headache over months, and she had a past medical history of COVID hospitalization. So she had a COVID pneumonia that was also treated with corticosteroids, and it also came out that she was in prone position for 5 weeks. And later, during the whole process of solving the case, thinking of chronic headache, also trying to think of, okay, due to her COVID infection, maybe she could have had some, due to the hypercoagulability, maybe something like dural venous sinus thrombosis, something like this. And then also because she was pre-diabetic, she was exposed to corticosteroids, maybe she could have something like a fungal infection, especially thinking of mucormycosis that was in the discussion. But she also had a lesion on the forehead. So it was like a subcutaneous lesion. And it later actually came out that it was a chronic mucormycosis infection. And I remember that everyone was pretty shocked to read, like, what? A chronic mucormycosis infection, and it came out due to the prone position and the corticosteroids. Yeah, she was exposed to this fungus, I don't know. Yeah. And basically the questions, and then we were also talking about this very nice pearl that I wanted to mention is we were talking a lot about osteomyelitis. And when we were thinking of a solitary skull lesion, we remember the great case of Gabby, and it was due to syphilis causing a skull-based osteomyelitis. And then I tried to recap the differentials for solitary skull lesion again. So we think of metastases, based something like multiple myeloma, but also Paget's disease, or something like a hemangioma. And also osteomyelitis can cause it. And then we are trying to figure out basically what is the most common cause for osteomyelitis. It's actually, if you think Staph aureus is the most notorious one, but if you think of the more subacute ones, you think of TB, especially as we know, causing Pott's disease, because older people are more like, if you think of older people, we think more of a spinal manifestation. If you think of children, we usually think of the metaphysis of the long bones. Yeah. That's a summary.
So, that was an absolutely incredible summary of a mesmerizing case that I think had us all hinting towards mucor because of the COVID and steroids. But I think if you take those out, I never would have thought in a million years it was. And I'm really appreciated that DDX of a skull-based lesion. I remember now that we had an RLR with a hemangioma that I completely forgot about until now. I'll share one reflection. You have a patient with osteomyelitis. I would love for you all to guess what their average alkaline phosphatase is, because we're talking about alk phos, bone. What do you think the average alk phos is in a patient with osteomyelitis? Probably not high, says Amr. Hundreds? Why isn't it high? There's destruction of the bone. Usually completely normal. Completely normal. I know, I waited just in time for your guess, Shema, just in time. So what happens is So alkaline phosphatase is an osteoblastic enzyme released as part of the bone healing. Unfortunately, in osteomyelitis, the infection is so aggressive that it does not allow the bone to heal. So over time, over VMR, I promise we'll share the comprehensive differential diagnosis, but it is very helpful to classify bony lesions with alk phos elevation or bony lesions with a normal alk phos. And the DDX for bony lesions with a normal alk phos is really, really interesting one that unfortunately, because of my time management, we won't be able to talk about, but I think it was a powerful clue in that case. You know, you see like devastation and destruction in this patient's skull base, unfortunately, to the point where it was adherent to her dura, but her alk phos was completely normal. All right, last but not least, Promise, take us away.
I have 5 minutes. The pressure is really high.
Oh, you know, I don't know. I think everyone here, all 20 other people, are just excited to learn. So there is no pressure.
Can I try using the whiteboard actually?
Yeah, oh, do whatever you want.
Okay, I will try. Okay, how do I? Hold on. I definitely know how to use a whiteboard on Zoom. I've done that before. Or can I do it on the Zoom or no? I think I can.
Take your time. Take your time. We don't have to finish exactly on time.
No, I just don't see the whiteboard function here on my
really?
end. Yeah, I only get to share screen. That's okay. I will just walk through it.
Cool. Yeah, go for it.
Okay. So we have a case presented by Mukund, and it was extremely inspiring, but also a very educational case. There were definitely a lot of curveballs coming in, and also Mukund did a really good job of walking us through the challenges of providing care to basically street medicine, and in a very limited resource setting, still trying to get the important pieces for diagnostic pieces, but at the same time, addressing the patient's chief concern and really showing us what it means to provide patient-centered care to a very unique population, the homeless population. So we have a 48-year-old male referred to street medicine team for a excruciating back pain. So if I were to have the whiteboard, I would draw like a stick figure. I am very bad at drawing, but a stick figure of a 48-year-old male. And the first problem is there's a back pain. And so that's kind of where we really focus on, and Robbie and Reza did a really good job talking through like the differential diagnosis for back pain. And I think the main takeaways is we really have to see if there are any signs and like alarming signs and symptoms that make me concerned of like a compression or some sort of like malignancy, especially for this population. We really have to keep TB in the back of our head. And then, they may also be immunocompromised like HIV, and they, have maybe a history of substance abuse and like IV drug use. So all of these things, we really have to take all of that into consideration once, like a patient like this presents with back pain. And then we found out that he actually has like a left testicular swelling a few months ago. And so that really kind of, I think it was like a very interesting turn, because now we're wondering, okay, was this a metastasis? Like maybe he had a testicular cancer and then it metastasized to the spine. But I also think that we had a really good discussion about how this patient has a long history of mistrust with the healthcare system and addressing that challenging aspect, as well as also maybe his testicular swelling wasn't addressed properly. And I think one of the pearls that I got and I kind of looked into was like a differential diagnosis for testicular swellings. And so like some of the, like, I think the really important diagnosis that we do not want to miss is like a acute testicular torsion. And I also learned that TB could also go to the testes and have like a GU TB picture, where it would lead to, there were 2 case reports that shows having like a chronic testicular swelling and or maybe like an epididymal involvement, but usually it's very asymptomatic. So I like, that's definitely like a pearl we learned. And we definitely talked about the past disease of TB And that was like really high on the differential when we were talking about the back pain. And then I think it was so then we talked about the physical exam in a very limited setting. And I think we were really talking about basically trying to do as much as we can in there with like very little resources. Like we could only do so much, especially because he couldn't even get up to do a neuro exam per se. So what we were really trying to talk about with the back pain is like, were there any upper motor neuron symptoms, the tenderness to a spinal level, and then the fact that this patient has a bony protrusion at L1, and then is tenderness to palpation, and then having like numbness. We were really concerned. And then the twist and turn was like, after months of Mukund and his team's hard work of helping this patient to find housing, really helping him to put his life into a more stable state, and something that he really wanted, that he got like into a trailer housing. When they visited him again, they found that he has like a 10 out of 10 abdominal pain spasms that's worsening, and also like numbness and tingling in his bilateral lower extremity. So then he was admitted to the hospital at that point, and then they were able to run blood tests and then also imaging studies, and they found that he has many health issues, including cardiomegaly, hepatomegaly with ascites, and then pericardial effusion, ankylosing deformities. And his echo was like 8% of ejection fraction. And unfortunately, this patient ended up dying when they found him again. And the autopsy showed a dilated cardiomyopathy.
Yeah, it was such a, I mean, I don't even know. I feel like we should reserve a whole hour just to reflect on this case, but promise you, like, I don't know. I feel like the nervousness has pushed you to like iron out this case in a way that you walk through every single pivot point in such a clear manner. And I think all of us, like ending with heart failure, were utterly shocked in real time that this person had that. I also really like the review on testicular pain. I didn't think we were going to be able to learn from that, but that was really, really cool to hear. Folks, I think we have a lot to learn with this new format, and if you're part of the team and or did teaching, if you can hang out for a few minutes after, so we can reflect and debrief on this. But I will try to summarize one pearl from each of the 6 cases, and thank everyone else who has joined us today. So for Sunday's case, I think the key principle in hematemesis is to have 2 different approaches: an anatomic one, all the way from nose all the way down to the ligament of Treitz, but also have a practical one. Is this patient having cirrhosis or having non-cirrhotic bleeds? I think the most practical takeaway with Monday's case is to use your ALK-Phos data wisely. No pain equals no bone. A positive DGT doesn't mean that the bone isn't also involved. For the POCUS, I really think that a simple approach is to say, does this patient have neuro issues, have medications on board? And if not, it's probably BPH. If yes, it's probably one of those things. For Wednesday's case, I think Amar and Madalena walked us through a great approach of pseudobradycardia, and it fundamentally boils down to you are beating too fast or you had a premature contraction. So not all causes of a pulse ox with a low reading are actually bradycardia. On Thursday's case, I think you can be humbled by the fact that skull-based osteo can occur in a chronic manner from Mucor, and ultimately people's background, COVID and steroids, can sometimes dominate the clinical presentation, and leaning heavily on those allows you to come to the answer. And I don't know how to reflect on Friday's case. It was humbling, truly, and I think it goes to show you that patients, when they come in with one concern, and that concern may be colored by discomfort and pain, may have a completely separate life-threatening issue that you really have to keep your eye out for. It was a treat. Learned a lot hanging out with you all this week, and we really wanted to thank you. I'll stop actually, whoever hit the recording, please go ahead and turn it off if you can. And I will ask